And that's what we have done. We've learned a lot from the previous NHIF, and we've put in place the proper regulations, because that is now run under different regulations. It's not run under the Social Health Insurance Regulations or Act. So we've put an end to that, Honorable Nyikal. I just wanted to inform the members.
Yes, CEO. No, it is the PS.
So I think, Chair, you have directed that we go back. I hope all members have received the copies where we are showing the detailed tariffs and benefits. I said the table has the benefit packages, description, tariffs rate, and co-payment. And the first one is the primary health care fund, where eligible beneficiaries shall be SHA-registered members. Chair, on the benefit packages, we call it essential outpatient service. The description of the service is listed there. For the benefit of time, Chair, I think members have this copy. And then the tariff rate is global capitation of Kenya shillings 900 per beneficiary. Co-payment is none. So you go to the primary health care facility level 2, level 3, and some level 4, and you'll receive essential outpatient services, which have been listed there. You must have this copy. Under the benefit packages, inpatient description, Chair, I've put there the description. The tariff rate daily, we call it per diem, of Kenya shillings 2,240. The co-payment is the difference between the SHA tariff and the invoice amounts billed by each facility. So if you go to the facility, the tariff there is 2,240, and if there is anything over and above is what you call the co-payment, and that's what you'll pay. The other benefit package is screening. The description is there. The tariff rate, Chair, this is work in progress. That means it's not been gazetted. And that's just the co-payment will be the difference between the SHA tariff and the invoice amounts billed by each facility. So here we have not given the rates. This has not been gazetted. Optical services, the description is there. The tariff rate is provider payments mechanism, fixed rate of Kenya shillings 1,000. And then the difference is between the SHA tariff and the invoice amounts billed by each facility. If you go, for example, to the optician, the amount that you are entitled is 1,000. And if it is over 1,000, then you will pay the difference. That's the meaning. Social health insurance
this
fund.
1,000 is for the whole family or for individual?
The director, benefit packages, Tracy Jones, to give us more details.
Thank you, Honorable Chair. For the optical package, the fixed rate of the 1,000 is per household per year.
A household per year?
Yes. Okay. Sorry.
Okay, continue.
And,
Chair.
It is 1,000 per household per year.
And then what it is doing eye test, treatment for refractive errors through eyeglasses. Which glasses? You're going to get for 1,000. Even for children, glasses. And you have examined them.
It is both the eligible parent plus the children under 18.
Eligible beneficiaries are okay.
Eligible beneficiaries, children below 18.
Yes. If you have a child who is above 18, you don't get it. But I think the issue here is the amount.
I think that's my point.
1,000 per household.
Yeah, I'll move to social health insurance fund.
The rationale behind the rationale and the adequacy of 1,000 shillings under optical care.
I'll give to Tracy Jones to give us a detailed response on that.
Tracy Jones.
Thank you, Honorable Chair.
You are a medical doctor by profession?
Yes, Chair.
MPCHB?
Yes, MBCHB.
Uh-huh.
Health Financing, MBA, and MMed.
Okay.
Yeah.
Now tell us, 1,000 or that.
Honorable Chair, the tariff that is provided for these services, this is one of the critical areas that had to undergo optimization in view of the resources that were available for the primary health care fund. And when the optimization was done, the amount that could be allocated that was feasible under this particular service, when we were adjusting the benefits tariffs to the available resources, is what informed starting off with the 1,000 for a household per year. However, in the detailed design of the benefit package, we had hoped to allocate more. And when the fund...
What is the optimal for, from your point of view? How much should we have allocated there?
I would refer, because rising on the children who are going to school, because of the need to make it available, the glasses available to the children. I know
you are struggling. Let's continue. You not convince us on that, because 1,000 for classes. There is no classes that you can buy for a household in a year for 1,000. So you know that. Yeah. So, yes.
On this one, and this also covers the dental services. You see, you have tried to shield SHA from paying for these services despite patients paying contributions, because you have taken it to the primary health care fund. And therefore, the way to cushion Kenyans is to ensure that then SHA, a chief, has a package, so that I has a dental package and an optical package. So once I exhaust my primary health care fund entitlement, the difference, instead of going to out of pocket, is paid for, irrespective of the level of the facility, from chief.
Proposal. Yes. Let's look of ways of making this UHC work. Yeah. Let's not give excuses by trying to be clever and move around, because 1,000 for a household for optical services for a whole year, sure, that's not it's not realistic.
And Mr. Chairman,
we are doing the service to the public.
And Mr. Chairman,
and Chair.
Sorry.
And for dental, you are actually paying 2,000 per year per household. You are only encouraging the extraction of teeth, which is criminal according to the WHO Oral Health Charter. We are now preserving teeth. The way God created us, you are supposed to go to your grave with your teeth.
But you know we've been extracting teeth, Honorable.
Yes, Chair. We are shifting as oral health care providers. We are shifting from teeth extraction.
Mr. Chairman, I was still on the optical.
There are also teeth extraction for cultural purposes.
Yeah, that's right. I was on the optical one, because I don't know whether. I think that this should be enhanced, especially because in some areas, optical issues are infectious diseases that might affect the whole household.
Like trachoma and other things.
And if you have a household that is suffering from an optical problem, it's an outbreak within a family, and all you can give them is 1,000 shillings per year, I think that is
many of them will go blind.
Many will go blind, yes.
Yes, Cynthia.
Honorable Chair, this is just a comment, Honorable Chair, that we cannot take public money to do market survey like you have properly put it in regards to the cost of a service, and then we just conveniently put it somewhere and lie about the figure, just like you have put it, Chair. I want to encourage the ministry to be very honest about it. Put it out there as bad as it is or as good as it is. I think that serves us better, other than lying, and then it comes out as this pathetic. It's really discouraging, and you know the facts.
Proceed, PS.
Yeah, let me Chair, just a little bit back. This capitation per beneficiary, in real terms, At those level 2, level 3, and I think outpatient level 4, and even do we actually have the numbers, the population upon which the capitation is calculated? Because otherwise, the 900 would not have a meaning at all. And I don't know how you will say this facility will give you so much times 900 and this. And then the reality is, are those populations real? Because the thing that will go with that is mobility. Because if you now say, this person, you serve these people, if this person moves to another place, is there mobility? Why we are saying this, some of these things, people meet them in reality. Because that's interesting.
Thank you. I'll respond to Sunkuli's question, then I'll allow the CEO DHA to respond to Honorable Nikal on the issue of the numbers. I think I want to agree with you, Honorable Members, as asked by Honorable Sunkuli, the amount is less than what even you can access in the market. What we have done, Honorable Members and Chair, is that we have established a tariff and benefits review panel or committee that will now start reviewing some of these tariffs that we had gazetted earlier. As mentioned by Dr. Tracy Jones, this came as a result of also the optimization, where when the finance bill did not go through, there was a review, and therefore we are also urged to do a review on the primary healthcare benefits packages. So it was reduced to that level of 1,000. But I want to assure you, honourable members, and these are concerned to everybody, we have now subject this to the Tariffs and Benefits Review Committee, which will then give us the next tariffs that will be gazetted thereafter. So you will see an improvement on this, honourable members. On the issue of capitation and the members, the beneficiaries, the registration is done through the system, so I'll allow the acting CEO DHA, Anthony, to respond.
Thank you, Honorable Chair and Honorable Members. So for capitation, this is what we do. The population is the number of registered Kenyans for a specific area. Now, when you get that population of number of registered Kenyans in that specific areas, you have the facilities for level 2 and 3 who have provided services under SHA for last quarter. So you use that data to create a formula that shows you of all the treatments. So assuming an area has 100 people, for example, and 10 got sick, and you have 5 facilities, and facility number 1, for example, treated, out of the 10 people, they treated 2 or 3. We will calculate a formula to show which facilities are seeing more patients from the previous quarter's data, and then we use them to pay capitation for this quarter. This year and this quarter, we're going more to even identify which services are you providing, and then we triangulate a formula on that so that we calculate how much within that population are you providing the primary health care services. This will keep improving as we get the data within the system. But currently, we're using the population as registered under SHA. So a specific area, for example, if you call PCN, let's say it's a county, how many Kenyans are registered under that, then that gives you a value of how much capitation you need to give per quarter, and then you calculate according to facilities data of the previous quarter, how much patients have they seen within that time period of time.
Your attention. If I know that, and I know that's what you have used in that area, then I just get hashed to people and they don't come to me, but I've got the capitation. If I know, because it's apparent from what you are saying, that you don't have names, numbers, and so on of the people. It is generally the population around there, isn't it? That's what gives you the number. Now, yeah, the number, right? Yeah, for planning. If I also know that I'm a service provider and you've given me that money, and if I now make sure that I discourage people from coming, I retain my money. The point is difficult. But
how do you make sure that the service provider renders the services?
You know, they render these services even if they're under PHC online. So a patient will go there, they do eligibility, and they get a service, and we actually see that that hospital saw this patient and treated this patient. So we use that data to justify that. But remember the capitation of the 900.
You are using what, biometric or OTP?
Currently we are using OTP, but Chair, this month, I think on 28, we are starting the rollout of biometrics. We're using OTP now for the whole social health authority, whether it's PHC, SHIF, or any other services. But we are rolling out the biometrics.
Okay, but
Chair, I have one question in that area. So as at now, you should be able to tell us how much has gone to the FIF accounts of the primary healthcare units. And number two, the other biggest gap is that I am getting identified at the point of first contact with the facility. At the exit, it's not possible to tell whether the prescription that was given was dispensed or not, whether the lab test was carried out or not. And therefore, in terms of the completeness of the service provided, how do we seal that loophole?
Yes.
Thank you, Honorable Chair and Honorable Members. Yes, we have data of each and every facility that have been paid under capitation by SHA. So that data is available per facility because SHA also paid directly to the facility. For the last quarter, as the CEO indicated, they paid 1.3 billion. This quarter, we are using the last quarter's data now to calculate. SHA will be making
level 2 and 3.
Yes, they all
Level
have
2,
bank
3, and 4.
Yes, they all have bank details.
Oh, I know they all have. Okay. We'll visit. Don't worry.
How many facilities is one entitled to?
You know, Honorable Maingi, when you take a mic and you start asking without the approval of the chair, then I'll declare
I'm sorry, Chair.
Out of order.
I'm guided.
Okay. I wanted him because we need to make progress. I'll just allow a very quick one and then Mathenge so that we can proceed.
Thank you, Chair. I just wanted to know how many facilities is one household entitled to?
Chair,
yes.
This time, because of digitization, we are not restricting you to a particular facilities because your data is available, it can be accessed in any facility that you visit. So you will not be restricted to a facility. You're not tied to the facility as previously done by NHIF.
Okay. Yes, Mathenge.
Chair, my request is that moving forward, a SHA, SHIF, and the primary healthcare fund must stop becoming just a cash cow for dispensing money, sending money to facilities and providers without ensuring that the service has been provided. Because what is happening, patients are only receiving prescriptions. You go, you will find the clinician, you'll find a prescription to go to the lab, but you cannot. The lab services are not available. You have to go and pay. You get a prescription to go for an X-ray, and the X-ray is not available. PGH Nyeri, the prescriptions for CT scan and MRI are all being provided either at Madari Mission Hospital or at Outspan Hospital. Yet, when the patient goes there, there is no way of shift telling whether this service was provided, and the hospital will bill for the full amount despite patients paying.
Okay. I think that's a good feedback. That should be able to inform how we move forward. Yes, PS, proceed.
Thank you. Thank you, Chair and Honourable members. I will now move to Social Health Insurance Fund. Shift the eligible beneficiaries shall.
I think we can be able to look at them there.
Okay, you can just look at the.
Yeah. Is there anything that you think you need to pinpoint out that is of particular
I'll move
interest?
to maternity, neonatal, and child health services. Chair, just for information purposes, under Linda Mama program, which you are aware, now for those mothers who are indigent, not able to pay, teenage pregnants who are not able to pay their premiums contributions, or they have not paid their social health insurance fund premiums, they will be paid under the Linda Mama program, and they will be eligible for, they will now, both the household will be insured for a period of 1 year, as opposed to what NHIF used to do before, where they're only paying for delivery. That's the shift that we have here, Chair. Chair, again, you look at the Chair, I want to bring the issue of overseas treatment, which is
about newborn. If a newborn gets sick, this changes under maternity, neonatal, and child care. Because you are saying normal delivery in the essential newborn care. Essential newborn care, that means the baby is okay, maybe just vaccination. And what about the baby gets jaundice, is going to do exchange transfusion, and so on? What then happens?
Chair, as I said, under Linda Mama program, they will now be entitled to the normal medical cover under SHIF, where they will be treated as members, paid up members of SHIF. So they will continue receiving treatment, not only at that particular time, but for a period of 1 year. The premium will now run for a period of 1 year.
And cesarean section, if there's a complication?
Similar to the cesarean section, if there's any complication, they will continue getting treatment because they are already paid up members of the SHIF, so they're entitled to the payment. So I want to move to, in particular, overseas treatment.
Chair, can we get one confirmation, PS, that therefore a street mother, a mother from a street family in Nyeri, walking to PGH Nyeri and receiving, walking to PGH Nyeri for a delivery, immediately they get to PGH Nyeri. Upon confirming that they are not registered, they should be registered instantly.
Agreed.
All right.
So let me go to the overseas treatment.
Mr. Chairman.
Yes.
Yeah.
They should be registered instantly.
Agreed.
All right.
So let me go to the overseas treatment.
Mr. Chairman.
Yes.
Yeah, the PS is skipping the renal part. And I was just wondering myself, those figures that we have, what are they based on the market survey or public participation, or how do you determine that that is what you do? Because what is killing most of the renal patients is the post-operation, the post-treatment care that is lacking. If you peg it at 200,000, that is the maximum for that particular component. Is it based on what the ministry officials or experts have observed, or is it something that you get from the market? Because I don't know whether the figures are just arbitrary or how are they arrived at?
I'll give the floor to Tracy Jones, Dr. Tracy Jones, to give us how we arrived at the figures. It is not arbitrary, though, but she will be able to respond.
Thank you, Honorable Chair. In response to renal care therapies and the renal replacement therapies, the cost or the tariff that is indicated, this was informed through a thorough costing of the requirements or the inputs that go into delivering this particular service. All the inputs were considered, and after the costing was done, there was a thorough engagement of the stakeholders to review the amounts before the tariff was set. And that, when it was gazetted, it had been validated as a tariff that was covering the actual cost of that service. However, for the post-renal transplant, the replacement therapy, this one is a new service or a new benefit that has been added in this particular benefit package. And this was to try and make sure that those patients who are undergoing dialysis but do qualify for transplant can be able to undergo transplant because before the cost of the post-renal replacement was too costly and most of the patients were remaining on dialysis lifelong. Because we had hoped to include more money for the post-renal replacement in the ECCIF, the SHIF package was to carry a bit of it, which is as reflected as the 200,000 per household per year. And we had factored in a lot more of that post-renal replacement therapy in the ECCIF, which we have since shelved until we activate the chronic part of the ECCIF with availability of resources.
Mr. Chairman, but in particular, if you may allow me to ask this one,
yes.
What does it actually cost? What does the renal transplant actually cost? What does a patient pay if you are looking at the market, the ordinary patient?
Thank you, Honorable Chair. In terms of the cost, as we said, the billed amounts are variable depending on the facility that is visited. So this tariff that is indicated for the transplant as a surgical package does take care of the surgery itself, and in most facilities, there is usually no need for a co-payment.
This is how much they charge. At KU Teaching and Referral Hospital, this is how much they charge.